everyone, and thank you for joining us today on this wonderful afternoon here. I guess it depends on where you are, right? But thank you for joining us today, and we've got something really important and valuable to talk about, and that is dental health and preventive dental health in people with intellectual and developmental disabilities. You guys probably know me. I'm Craig Escudé. I'm a family physician. I've spent the majority of my clinical career providing healthcare for people with intellectual and developmental disabilities. And I've written a book called The Clinical Pearls in IDD Healthcare and an e-learning course for healthcare providers called The Curriculum in IDD Healthcare. But I also want to mention the IDD Health Matters podcast, which I host and we've had over 140 episodes out at this point and growing, and it's a great way to learn more about what people are doing in this field. So take a look at the IDD Health Matters podcast. I'm going to now turn it over to a dear friend and colleague, Dr. Alan Wong, who is our guest today, to introduce himself. Alan.
Thank you and welcome everyone. Dr. Escudé, it's an honor and privilege to be here with you. You're such a champion in the education field for IDD and such a strong advocate, so proud to be with you. My name is Alan Wong. I'm a dentist by training. I trained at the University of Pacific School of Dentistry. I became an educator as well as clinician because of passion. I really like teaching and I really like to keep up on things. So I taught pre-doctoral and postdoctoral education, mostly residency, and stumbled into this field of IDD and DDD care. Because in dental school, we weren't taught this. You know, I didn't learn until I was in residency and realized the importance of learning this. And so I've taught for about 38 years. I retired from the University of Pacific as a professor emeritus in the area, but enjoyed teaching a lot. I became an advocate, if you will, by need and desire, because I realized what a injustice it is for people with IDD to receive health care, particularly oral health care. I've done a lot of hospital dentistry, I've done a lot of clinical dentistry, and I realized the fact that too often we rely on the hospital or general anesthesia for the care for our patients with IDD, and that's not equitable. That's not something we would have. So I've been a champion in terms of two things. One, in advocacy for people with better health, but also in a minimally invasive technique and minimally invasive dentistry. So I'm looking forward to sharing with some of you and answering questions of you how we can better improve oral health. I've been a national and international lecturer in this area, particularly in minimally invasive dentistry. I've been a former global clinical advisor with Special Olympics, the Special Smiles program, along with Dr. Steve Perlman, a wonderful mentor of mine. And the same problem exists not only in the States, but in 175 countries as well, that the #1 unmet need for our population with IDD is oral health. Oral health is quite a challenge. So what a great topic to discuss today. I'm very involved with organized dentistry in the area of IDD care with the American Academy of Developmental Medicine Dentistry as past president, and also Special Care Dentistry Association as past president, and the CAMBRA, or Caries Management by Risk Association Coalition president. I was attracted to Nashville after I retired from teaching to help create a transdisciplinary clinic in Tennessee called Kramer Davis, which is very beautiful and wonderful because it integrated both medical and dental services. So we had medical, psychiatry, OT, PT, speech language pathology, behavioral support, along with oral health. And what a beautiful model that was. And it sort of reinforced the fact that this is something it's not a single isolated incident of dentistry, but it's dentistry and medicine. So as I was retiring from that, I was recruited to Renaissance Dental Insurance, a subsidiary of Delta Dental of Michigan in Tennessee, to help become their adult IDD dental director, to help improve dental insurance coverage for our population. So that's me in a nutshell.
Thank you, Dr. Wong. And you know, I know everybody can see why I'm so excited to have Dr. Wong with us today, because he is very well qualified and experienced to talk about our topic today. So let's start with what are some of the problems? What are some of the causes for poor overall dental health in people with intellectual and developmental disabilities?
Well, that's very good. I kind of alluded it earlier. The lack of training from oral health care providers, dentistry, hygiene, specialty, even medicine, because we don't look for things we're not really trained to look for, and we don't treat things that we're uncomfortable with. So not only the population is something that in dental schools in the past and medical schools, I assume, we have limited experiences with our friends with IDD and our friends with any physical disabilities in total. So with that sheltered kind of experience, unless we go to a residency program that has that availability, we are good at what we know to do. And if we're treating neurotypical patients all the time, cash paying patients all the time, people that aren't Medicaid all the time, we sometimes miss the beauty of taking care of the whole population. So I think the lack of properly trained healthcare professionals to not really do the technical part, but meet people in different statuses, whether it's socioeconomic or whether it's physical disabilities or whether other challenges in medical health. And so I think feeling comfortable, having access to care is important. We're going to talk a little bit about social determinants of health later, but I think there's also that because we're not well trained, sometimes there's an unconscious bias. We don't feel comfortable. And when we don't feel comfortable with something, we don't tend to do it very much. Sometimes we have W and L, which people say within normal limits, but a lot of times it's we never looked.
Yep.
And so we never look to seek things that we want to see and can see. And if someone is a little bit challenging, takes more time, we as clinicians sometimes just say, well, we'll go past that and we'll look beyond that. If someone doesn't want to open their mouth, we don't look in their mouth that much. It's not because they don't want to open their mouth, it's a trust factor. And we're going to talk a little bit about that. Other things of unconscious things could be that we forget about the genetics. A lot of patients have different syndromic situations that create things that we don't think about, whether it's the development of the body and the teeth and the gums, whether it's the development of the jaw structure, whether it's how they breathe. We don't think about that. A lot of times people are mouth breathing because they can't get enough air. And so, we have to look at the person more about their teeth and gums. We have to look about their whole systemic way they function, their cardiovascular, their renal system, how they process things. And so genetics has a slight play in caries, dental caries, or cavities per se. Some people are genetically predisposed to have dental decay. And so there are some genes that we found in the markers that sort of move towards that. That's not an excuse for getting dental decay. It just means you're at a higher risk of getting that. And you're all about risk prevention. So it's not an excuse, but it's something of a risk factor. So if we know it's a risk factor, we have to be able to change our lifestyle habits to account for that with more prevention. So some of our population, unfortunately, they're challenged because not only is it difficult to find people who are willing to see this population, unfortunately, it's sometimes a distance, and they have to go travel great distance to get there. So social determinants of health in terms of transportation, some people are reliant upon ride sharing, or they have to get special vans to bring them. And sometimes those people, scheduling them for appointments is not very easy, it's not very convenient. Or sometimes the transportation comes late or arrives too late, and then all of a sudden you've missed an appointment. So some of these things aren't because patients don't want to get there. Sometimes it's a difficulty for them to get there. And then the offices think that, oh, well, the patient didn't want to come, or they're always late, or they take more time. And that becomes that unconscious bias about they don't care, they don't want to care. But in essence, they do want to get there. They just can't get there because they're relying on some other factors. Poverty and insurance. Most patients sometimes end up having the insurance of Medicaid, and the coverage is challenging because they don't cover for everything. That's something a social determinant can be problematic with, or the pay that a Medicaid might offer clinicians may not want to take. And that's also that barrier that causes the poor overall health because it's not covered, and it's not covered at the level and rate it should be covered. People with a higher caries risk or extreme caries risk, they need to be seen more frequently, but yet insurance won't cover for it. So those are some of the factors of what causes and contributes to poor oral health. And so
yeah, you covered a lot of very important issues, and one of the biggest ones, you know, that we've talked about before, including in the medical area, is just the lack of training and the lack of comfort of clinicians many times in providing medical care or dental care for people with intellectual and developmental disabilities. And we strongly advocate all the time for inclusion of training in health professional programs for people to understand and to know how to meet the health and oral health care needs of people with intellectual and developmental disabilities and other disabilities. Very important. You know, what I think is interesting is the connection. I know as a medical provider, I haven't always thought about this, and I learned a lot of these things from you, but how poor oral health can affect other health conditions. There are other things that can be affected. So let's, if you would expand on that just a little bit.
Well, great. Thanks, Dr. Escudé. You're right. You know, both medical and dental, we need more training in the integration of the oral systemic connection. And so this goes with not just for IDD populations, but all populations, because oral disease does affect systemic concerns of each individual, more so than we thought. At one time, we thought, well, it's a fleeting kind of thing. I'm going to put in the chat a very good article after I cover this slide for you to look things up about. But if you don't think about it, periodontal disease or gum disease basically is an inflammation of the gums secondary to factors such as calculus, tartar, plaque, and more importantly, bacteria. If you have an accumulation of bacteria, it can get into your bloodstream through your gums, from the bleeding gums into your system. So a periodontal disease is chiefly concerned about the inflammatory response of the body, not just related just to the gums and teeth, but throughout the whole body and systemic, because blood travels throughout the whole system. So this chronic inflammation of the system elevates your whole body system. It can cause bacteremias in different areas. It can increase vascular inflammation. It can increase insulin resistance. It creates a local immune response and releases what's called cytokines. I won't get into specific cytokines, but increases the C-reactive protein as well. So all this having chronic inflammation all the time creates your body to be elevated in an inflammatory state chronically and affects things such as the heart and increases atherosclerosis. It's that's from secondary inflammatory cytokine from the bacteria. It can increase other systemic factors in chronic obstructive pulmonary disease, increase pneumonia chances, increase rheumatoid arthritis, chronic kidney disease. It is even thought to, the plaque is even thought to increase Alzheimer and hypertension. So a lot of these things, just in the mouth and the cells, the gateway to your whole system, the bacteria and the inflammation is very important. It also can affect preterm birth weights, and there's a vertical transmission that anyone with gum disease can transmit it through their saliva through their loved ones. So there's what's called vertical transmission. So the mother who has cavities and gum disease kissing their baby lovingly is actually spreading bacteria to them. So this is not exclusive to IDD, it's to everyone. So understanding that if we can reduce bacteria in our mouth and reduce the inflammation, we can improve our health, but also the ones that we love that we share with. So, basically, those are the things that poor oral health we don't think about because we don't look. We never look, and we never think about it. But it's easier to ignore things sometimes. But Yeah, so thanks.
Yeah, those are such important points that we really don't always think about. Not just that the person will have poor oral health or lose teeth or whatever, but it can also affect their heart. It can affect other aspects of things in their body, including their kidneys and so many different things, as well as other people. So many reasons why it's important that we help everyone have the best possible oral health that they can have. So sometimes, we talk about this, sometimes it can be challenging in people who maybe have some tendencies to have some challenging behaviors, or, I will just say a lot of us don't like to participate in an oral health visit, right? We're not always excited about going to see the dentist. So what are some ways that supporters in the field can help improve the overall experience for people with intellectual and developmental disabilities to facilitate better visits and better outcomes?
That's an excellent point. I just want to cover a few more things about the oral health now that I think
sure,
about.
Sorry.
Yeah, no, that's fine. The other thing is sometimes we don't think about it, but a lot of our patients are challenged with breathing and mouth breathing, which is something very, very important, as well as snoring and sleep apnea. So dentists, a lot of times we see patients that we don't think about, or we don't ask the question, do they snore? Does your child snore or your adult snore? If they do, they probably need to be referred out appropriately. But sometimes we forget about making those referrals because we go, oh, that's part of their condition. And it isn't, because that contributes a lot to the oral systemic health in terms of hypertension, cognition, having a restful sleep, and other things. So poor oral health not is only gums and teeth, but it's also how they function. And do they chew well? Do they swallow well? That can also cause gastrointestinal problems if they're just swallowing chunks of food. So oral health covers a major gamut. So how do we support successful dental visits was the question.
Yes.
I think that because there's so few care providers, sometimes it's a rush to get into an office, and because dentists and physicians are limited because of time, they only have a certain amount of time that they have with someone. So there's a certain threshold of tolerance, if you will, time-wise in the schedule. So the key basically is to make that appointment as productive as possible. And to do that, we make sure that the patient is comfortable. So sitting in your waiting room can be very anxiety fulfilled. So if your patient is sitting there and you're filling out all the paperwork, it can be taking 15, 20, 30 minutes, which causes anxiety. So then the patient gets really upset. So I would suggest sometimes doing the paperwork in advance and preparing the office for what to expect. So and also prepare the patient for what to expect. You can schedule an office tour so the patient can see what things are, where things are, and the innate quality of what the smell, the sound, the look is going to be, and whether they can go through a tour quickly and see if there's certain things that are going to upset the patient, the lights, the sound, the noise, whatnot. An office tour would also give a face to the person and utilize that time. That 5 or 10 minute tour might be all it takes to help desensitize the patient to a new environment. Completing the paperwork in advance helps to limit patient having to wait in the waiting room. And if the doctor's running late, maybe the doctor can communicate that we're about 15 minutes late and not come in as early. Things of that nature. So when the patient can have a successful visit, they come in, they are treated, and they go. Now that said, it's like eating a pizza or pie. Not every person eats the same slice of pizza or pie, right? So you may have to think about your first appointment, not trying to do everything. And a lot of times the patients I see, they want to do everything because they haven't found a care provider. So the thing is, we cannot, in our mind, go further than what the patient can tolerate, because every person has a tolerance. And until we develop that trust, that tolerance may need to take the time to evolve until they trust you. They can do a lot of things once they trust you. So preparing the office is by sharing the office what the patient's preferences are. Things like what were their past experiences, positive and negative, what didn't go well, what went well. By preparing the patient, preparing the office to what to expect will help make a successful visit so they know what not to do, particularly when it comes to sensory needs. If your individual, your loved one is very sensitive to sound or light, letting the office know that ahead of time, we can accommodate certain things and not turn on the music too loud. We can dim the lights in certain areas. We can offer sunglasses. We can offer headphones or whatever wants to bring them. But basically preparing an office of who your loved one is and what's the best way to treat them, I think is key. Asking questions and adjusting the pace as needed during the visit and empowering the patient to be able to give a signal like, I have a question by raising your hand, or I feel nervous, raise your hand. Giving the person some tools to succeed and having them know that we're doing things for them and not to them. Often we're in this mode of I've got to do X, Y, Z in a certain order, and I've got to do it quickly. You may not do all the X-rays at one time. You might just take the X-ray that they can tolerate and then come back again to finish it out. So sometimes cutting the pie differently so that we can digest it is a better thing. And if the person has a comfort item that they always like to have, whether it's their music or whether it's some kind of stuffed animals or whatever it is that they feel more comforted by, if they have their own weighted blanket and they want to bring it, that's a great thing to help relieve the stress, because the stress comes from not knowing and the fear of who are these people. So whatever we can do to help minimize that stress, that's what we do to make a successful dental visit.
And I would add to that, make sure you not only bring the comfort items, but if there are any things that facilitate communication devices, things like that, make sure you bring those along too.
Yeah, exactly. If you can utilize specialists like BCBA, behavioral analysts, or registered behavior technicians, anything we can do to desensitize the patient through storybooks, through YouTube videos of what your first visit to the dentist might be, and preparing the patient at home with visual aids. Like I mentioned, sort of get them into the idea of this is what they're going to do. They're going to probably have you open your mouth. They're probably going to count. You're going to count some teeth, and then if you can sort of mimic that at home, then the visit when they get to the office isn't as challenging. Now, obviously, you're not going to mimic everything, but even the simplest thing is probably counting teeth and showing me how you're brushing your teeth, so they get the idea of what the dentist is going to ask them to do, and taking pictures and whatnot. But every office will have their own way that they want to orient the patient to. I would just say to that office, can we have a tour? Can you tell us what we're going to do ahead of time? And it might be, 5 or 10 minutes, but whatever. But it might be a great way to expose them ahead of time.
Yeah, and you mentioned doing things at home. There are some other things that people can do. We've got a lot of them, so let's kind of run through these pretty quickly, because I really want to get to the discussion on some preventive options out there as well. But let's talk about what supporters can do at home before the visit that can help.
Okay, great. Just like you prepare for a trip, you sort of go through a checklist of different things. Not that they had a bad experience, but what started, what triggered a negative dental experience, and if we can communicate, that's very important. Think about what's sensory sensitivities your loved one might have. What are some of the triggers? And by knowing these things and letting the office know ahead of time, it's important. But sometimes we're in such a rush to get that work done. We want their teeth looked at. We want their x-rays taken, that we forget that it's a person we're treating, not the teeth, not the gums. What are the things that we can help if the person were stressed? What will soothe them, whether it's the comfort item, but are there certain words that soothe them? Are there certain rewards that motivate them to do certain things? And everyone needs to know that there's a certain amount of time. Once we do X, Y, and Z, then we're done. And having a person understand what the length a person can tolerate is important. If you know your son can, or child, or your daughter can only tolerate 10 minutes of whatever, no matter how happy it is, no matter how great it is, if we know their tolerance level, it's helpful to communicate that. Can they tolerate headsets, headphones, sound mufflers, or whatever, anything to help the patient be more prepared, because in a dental office, often there is brighter light and there's an overhead light. If we know that we don't use that and we use our headlamp instead, it's an important thing for our office to know, so we don't agitate the person from a visual perspective. There are noises that in dentistry that you are not familiar with, the suction, the drill, and just preparing a person at home that you might hear this, you might hear that, and that tour might be helpful too, to expose them to the noise ahead of time so they know how to best prepare for that. Again, watching videos at home of like dental visits, and the office might have their own link for certain things, isn't kind of important. And I would go with that. Sometimes you can do what's called a telehealth visit, where you're doing a sort of visual thing to say, hi, how are you doing? So they know who they're going to see and who they're going to work with. Might be a familiarity type thing. So those are kind of the visits, those things that you don't think about when you go to the dentist, but it's important to prepare your loved one and prepare the office for success.
And we've got more.
Yeah.
Oops. There we go.
Yeah, thank you. Preparing the patient for any kind of visual, physical desensitization, practicing with the patient about their mouth awareness. You don't think about that, but getting them used to certain things. Often, if you don't have any tools at home, I take a plastic spoon and have them sort of retract or pull their cheek away so they can see their teeth, and introduce them to their teeth and count with them so they're used to it. And I let the patient be self-determined, basically, where they're retracting themselves instead of me always using my finger to pull away their cheek. I'd use a plastic spoon so it's a little more sanitary. But with a flashlight, sharing with them and showing them what to look at with a mouth mirror. This may not be easy. This might be something you just start with, looking at the front of the teeth and start counting the front teeth. But having them realize what you're doing is just looking is important. With a flashlight is kind of analogous to the light. So that might be helpful. Counting the teeth with like a cotton swab to get them used to having them open their mouth and having things counted, and having something touch their teeth will help desensitize things. Having them practice open their mouth and hold it for a count of 10 might be something that will help them to get an idea of, after I count to 10, I can close my mouth, so that they're not having to open their mouth forever. And like I said, using a flashlight or having them count to 10 is a very useful tool for us, so that we can see what we need to see. And you might prepare yourself for showing the dentist what you're doing for success, and then asking your child or your loved one, okay, Dr. Craig is going to take a look at your mouth now. Is that okay? We do things out of permission, because the mouth is a very personal area. So basically at home, you're simulating in a dental office, where they're in a reclining chair at home or where they're in the sofa at home. You don't have to do this in the bathroom. You can do it wherever you feel comfortable. And then what you're trying to do is evoke, they're opening your mouth and they're looking and they're checking, they're touching your teeth. If you can do that, excellent.
Great tips there for everyone to keep in mind. And when you sent your slides over, this one in particular caught my eye, because I really want to hear what you're going to say about it.
Okay.
And it's that one. So what's this all about?
Okay. All right. It's on the far right, you see the swimming pool. It's a beautiful clear blue water. And that kind of reminds me of, if anyone has had an aquarium or a swimming pool, jacuzzi, whatever, certain things have to be in certain condition and things are perfect. I mean, your mouth is the same way. Now, on the far left-hand side, whenever the acid level of the water becomes more acidic, it changes the environment and bad things grow. So the thing about dentistry we're finding out is no matter how much you brush, no matter how you floss, if the environment is bad, it's bad. We've got to correct the environment. And in the mouth, if your saliva is not protecting your mouth, then your mouth becomes more acidic and bacteria grows. And bacteria, this is for all patients, by the way. So understanding cavity risk or caries risk is important. So when your mouth becomes more acidic, bad bacteria grow, and bad bacteria, they eat sugars and carbohydrates in your foods and exude acids. So what happens is it's a positive feedback. If you don't have a good biofilm or in your mouth, which is the plaque, if the biofilm becomes acidic, it's going to attract more bad bacteria, and bad bacteria are going to create good bacteria to become what's called acetogenic and create more acids. So we get cavities not because we're not brushing. We get cavities because our biofilm is something that is consistently acidic, and the aquarium, the swimming pool, and your mouth are the same sort of thing. If you're not checking for the pH, the acid that's in your resting mouth, then you're constantly having acid in your mouth, and acid eats away at your teeth. We call it demineralize. When you demineralize the teeth, it takes all the calcium and all the ions and all the elements of your teeth and make them softer. And when it becomes softer, then that's how a cavity develops. Now, some of the risk factors.
Yeah, it's a great lead into the risk factors there.
One of the risk factors that we see that we are, do we have a lot of plaque? Is there an adequate salivary flow? Saliva is a key to everything. If you have good saliva, it's very hard to grow a cavity. So things that we often on our population with IDD are the medications that we prescribe. And as we get older, we also take a lot of medications, but we call them hyposalivary medications, or they cause xerostomia or dry mouth effects. About 80% of the medications that we prescribe create more of a hyposalivary condition, a dry mouth condition. How do we know that? Well, as a dentist, when we look in the mouth, when you have anyone open the mouth, they should have like a watery consistency of saliva, and they should have a certain amount of it that fill the floor of the mouth, if you will. And when you don't have that, when your saliva is very dehydrated, you will have lack of saliva, or you'll have a consistency change in saliva. The consistency, if it's bubbly, if it's ropey, if it's thick, or if it's absent, are signs that you are either dehydrated or your saliva is not producing protective mechanism that it should be. So sometimes we're drinking a lot of acidic beverages, whether it's juices, soft drinks, even sports drinks, that are acid-like. So in basic chemistry, the pH of 7 is neutrality. That's what we look for. So if you don't measure it on a regular basis, you won't know. So in caries risk assessment, we test the resting saliva. If it's 7, or if the pH is higher, meaning it's more basic, then we're good. It's probably very hard to grow a cavity. If your saliva is less than 7, then you're more likely to get a cavity. So the strongest thing, the hardest structure in your mouth is enamel. If you were to be dissolved in acid, the last thing that's going to go is your enamel. But even at enamel, the pH at 5.5 will dissolve. Now, that's enamel. Now, dentin and roots will start dissolving at pH of 6.2. So it's very important that just like the aquarium and the pool, if you were to have an acidic environment and grow bad bacteria, we have to shock it. We have to get rid of the bad biofilm or bacteria or plaque, we call it. And we do that with antimicrobials. And the 3 antimicrobials there are, mouth rinse-wise, there's sodium hypochlorite, which is a light bleach. There is chlorhexidine, which is an antimicrobial. And there's iodine. Povidone iodine works really well too. And we have to kill the bad bacteria and biofilm to grow a good biofilm, because not all bacteria is bad. Some bacteria is helpful and actually protective. So frequent snacking feeds that bad bacteria. So if you're a frequent snacker, the snacking is not the problem, it's the food that's left on your teeth. And often those with in our population, we forget about that. We give treats, we reward them with treats, and they're eating snacks all the time. So if they are going to have snacks, brush or have them rinse with water to get rid of the foods that are feeding bad bacteria, but also monitoring if their saliva, if they have enough of it, and if it should be watery. If it's not watery, they might be dehydrated as well. Often in our geriatric population and IDD population, we tend to forget about hydration, because the more they hydrate, the more they have to use the restroom. And sometimes we feel we don't want to be inconvenienced by that. But it's more important that whether you're IDD or non-IDD, that you are properly hydrated and that your saliva is good quality, that is neutral and not acidic. If you're wearing appliances like mouth guards or retainers or dental partials or anything that comes in and out of your mouth, those actually increase your risk for more cavities because it harbors bacteria. And you need to clean those appliances as well, because they also grow bacteria. And people that, I said genetics before, some people are genetically more inclined to have what's called deep grooves and pits in their teeth. Those are areas where cavities can grow quickly. And so to minimize that, we recommend sealants to seal off these grooves and cracks and nooks and crannies, much like when you wax the floor. You wax the floor to make sure things don't go into those little grooves that we can't brush and clean out. So those are some of the risk factors, but key thing is saliva and the biofilm. Managing that, if we can do that, we can't grow cavities as easily.
Very, very important topics to think about there. So let's talk about something that's always hard for me to pronounce: remineralization.
Correct. Okay, so I told you everything is based upon acids. Acids dissolve teeth basically, and they demineralize, so they take away things. But what's exciting and new in oral health now is we can reverse the trend. We can push ions and strengthen teeth. So cavities at one time was just a matter of when we fill the teeth. But if we catch things early, we can actually reverse the trend. We can actually stop a cavity from growing and strengthen that tooth, and maybe not need to do filling. So there's two ways of treating disease. One is surgical, where you cut into it and remove it, whether it's body or whatever. And there's chemical. Chemical treatment of teeth is teeth stronger, healthier, and better, even when they start dissolving. So if I know that your mouth is acidic and it's a pH of 5.5 or 6, and I know it's demineralizing, and how do I know that? Visually. If you dry the tooth and it becomes chalky, or the texture becomes different than smooth, then we know the tooth is demineralizing. Demineralizing is not the same as cavities. Demineralizing means the tooth is softening. So there are times where you can add what you're missing to remineralize a tooth. Now, in the saliva has everything, if it's healthy, to remineralize. However, as I said before, medication can cause impairment of your saliva flow and also function. So the 5 things that you need to have to remineralize, which saliva has also, are certain ions called calcium, phosphate, and fluoride. Those are ingredients, the building blocks of remineralization. Under a certain condition that the saliva is neutral and the biofilm is well controlled. Often we think about just giving more fluoride, more fluoride, more fluoride, but that won't remineralize effectively unless you have the calcium and phosphate, which is normally found in your good saliva, healthy saliva through food. Then that can be problematic. So we might have to supplement the toothpaste with some high fluoride or some additives such as calcium or fluoride, phosphate, to help build those building blocks to remineralize. So a good friend of mine, Dr. Doug Young, has always said it's like making a cookie. You have to have certain 5 ingredients and you have a cookie. It may not taste great, but you need flour, egg, milk, chocolate chip, and you need to have it in the right condition, meaning the oven's got to be turned on. So if you have everything, then things will work. And so the goal of minimally invasive dentistry is to identify what are we missing. So saliva, like I said, has mostly the calcium and the phosphate. So if you're missing good quality of saliva, you're going to miss the building block for remineralizing. So we might have to give you a certain specialized toothpaste that has calcium and phosphate, and even fluoride as well. Now, I know fluoride is a big issue nowadays. And so if you didn't want fluoride, you can do what's called nanohydroxyapatite, which is similar to fluoride, but it's not fluoride. But salivary pH is important to have it neutral and getting the bad plaque and growing a good biofilm. If you have those 5 ingredients, you can actually reverse the demineralization phase and not have cavities.
So before we get on to the next slide, which I really want everyone to hear about, I want to just say that we know that we've got so much great information here today, so we will run over the normal 45 minutes. So we hope that you can join us. If you can't, you will be getting a recording of this presentation as well, and it will be available on our website. So let's talk about SDF. What is SDF?
Okay. It's almost the greatest thing since sliced bread when it comes to dentistry. Silver diamine fluoride is a chemical. I remember I said you can treat things surgically or chemically. Silver diamine fluoride is a chemical or agent that is beautiful, and it's been used for actually a long period of time, over 100 years actually, but not been popularized to the last maybe 10 years in the United States. But it's a little liquid that we paint on a cavity, on a tooth that is, let's say, not all the way to the pulp, basically. We call it reversible. If it's reversible symptoms, we paint it on the tooth. It stops the sensitivity. It arrests the cavity by cauterizing it. And then it does the third thing, it remineralizes or strengthens the tooth. So how does it do that? It's made out of silver, which is an antimicrobial, and we use silver for different areas in medicine as well to cauterize. We used to use it in the eyes, and we use it in certain areas of silver nitrate sticks where we sort of cauterize bleeders. But it chemically kills the bacteria. And then the diamine fluoride is the fluoride is a remineralizer, the thing that makes the tooth stronger. And then the carrier is an ammonia component. So you rub it on the tooth and it stops the decay and makes the tooth harder. So that if I, the dentist, need to go back in there, I don't have to drill as much because the tooth is actually going to be strengthened. Now, we have to let the patient know that, or the caregiver know that the side effect is that it can cause the cavity to turn dark, almost black. And so here's a picture of what it might look like. Now, I often say a black tooth is better than no tooth. So it's a temporary kind of condition also. So it may turn it black, but after the tooth hardens, I can clean out the black part and I can fill it with a tooth colored material as necessary. So if you look on the slide there, the top is one of the front tooth, and some people say, oh, I don't like that. I don't like that. But what it does is it stops the pain, the sensitivity of the tooth and the dentin, kills the bacteria and strengthens and hardens the tooth. And then on the bottom, times 0 is when we see the patient, when we paint the silver diamine fluoride, and one day it looks kind of brownish, darkish, and then about a week later it becomes actually harder and darker, and it's less sensitive. So it's a treatment for sensitivity. It's a treatment to stop cavity from growing any greater, and actually starts reversing the situation, becomes more hard in terms of the tooth. So it's a really good way of treating a lot of teeth at one time. The nice thing is I don't have to numb up the patient. This can be done without numbing up the patient. The only negative thing is it has a little ammonia smell to it and a slight taste to it. So generally for patients with IDD, I generally find a fluoride varnish smell that they like, and I'll put the silver diamine fluoride, and I will put the bubble gum or whatever flavor they like smelling over that to mask that. And that's one of those things that if you know that the person is very sensitive to smells and taste, that's something that at the dental office we need to know ahead of time so that we can be prepared and try that. So silver fluoride, it's an easy way to stop cavities from growing in a lot of areas.
I've got a question for you about that. You know, sometimes getting to a dentist can be a many months long process. Does it have to be a dentist who can apply this, or there are others that can apply?
That's a great question. As long as you're trained in it, even medical clinicians can have a training how to place this on the teeth. Dental hygienists can do this, and in certain states, even dental assistants can help do this. But it is something that can be easily trained and taught in the medical field as well as the dental field. It's a great opportunity. Now, the only time you cannot use it is if the tooth is irreversible, meaning that the cavity is into the nerve or the tooth is dead, or has like an abscess. Those are irreversible situations, but this is what they train you in that advanced training. But no, dentists themselves don't have to do this. Dental therapists can do this in certain states. So I'm very much minimally invasive in my approach, and I'm so thankful for silver diamine fluoride that's come around, because a lot of people are able to be part of the solution, at least put out the fire, if you will, before we go back and fix things.
And is it a one-time treatment per carie?
It can be. Most times, if you're using silver diamine fluoride in itself, by itself, a lot of people think 2 to 3 times have an additive effect. Some people put on the silver diamine fluoride and then put the filling on top, a glass ionomer type filling on top, and they don't see the dark after that. But just to get someone in the chair and you see 10 cavities, if I can desensitize just to put on this silver diamine fluoride to make the teeth less sensitive, then they can brush their teeth better. If I can stop the cavity from growing, then I have less of an issue later, and that when I get to the person, I can do a filling sometimes without having local anesthesia. I don't have to numb up every patient. So that's another technique that's important. There's a new chemical also that's called Papa Carie Duo that is also something that eats away at just the cavity, and I don't have to do injection either. But that's a new material. I don't have a slide on that one, but in the papaya, there is an enzyme that's called papain. Papain or it's used to also tenderize meat, if you will, but it will eat away the cavity, and then you just spoon out the cavity and you put the filling on top afterwards. But we have newer sciences in terms of chemical treatment of teeth. So ask your dentist if they're familiar with SDF, and the other one is Papa Carie Duo.
Yeah, I think this is a great tool in the toolbox to improve oral health in as pain-free of a way possible and minimally invasive way as possible. Can nurses be trained to do this as well?
On silver diamine fluoride, nurses can be trained in it, I believe, and there are actually medical codes that are coming up, if I'm not mistaken.
Okay,
for medical.
Great. Where would people go to learn more about this, or how to receive the training?
Well, the only company I know that's really doing this right now is called Elevate Oral at elevateoral.com.
Okay.
Elevateoral.com.
Elevateoral.com.
Correct.
Great. Well, this is fascinating, and I think it's something that everyone needs to at least know about as an option to treat dental caries, arrest the decay process, give us more time to do other treatments that might be needed, allow a desensitization process to come into play, or for more intensive type treatments, things like that. So this is fascinating, which is really why I wanted everyone to really know about this. There's so much more that we can share, there's no doubt, and you can clearly see how much of a wealth of knowledge Dr. Wong is. Let's just, if you would, Dr. Wong, just talk about a few resources that are out there. By the way, the handouts are in your handouts tab. The handout for this presentation, the slides will be there, and all of these are links, so you'll be able to click on them to learn more about each of these things that are mentioned on this slide. So if you want to touch on a couple of these briefly, Dr. Wong.
Fantastic. Mouth rests are kind of important to get used to. It's like we call it tooth cushion. So if you click on this, you'll probably see a link that takes you to like a styrofoam kind of mouth prop that someone can just use and keep in their mouth for a while. It will help them to keep open for that 1 to 10 count we were talking about or longer, because it's something that they might have in the dental office, something that they'll put in their mouth to help hold their mouth. It's not to crank things open generally, but it's just to rest their mouth. The surround toothbrush, you may or may not have seen, it's usually a 3-headed toothbrush that just goes over the teeth and brushes, so you're brushing the front, back, and top of the teeth at the same time. It's met with mixed reactions. Some people really love it, and some people don't. So if you take a look at the picture of it, you may want to find out if it's something that's right for the patient. They also have these new electronic ones that have the full arch where it vibrates. Now, for someone, a lot of my patients, some of them don't like it all because it's so large and cumbersome, but some like the feel of it. So the key is you don't have to use one item to do something. You can try different items and adapt them. There's a lot of educational products. Cure Products has a nice soft toothbrush that the bristles are a little bit more comfortable, and that might be something for the sensory population. As long as it's cleaning the teeth, we're okay. Colgate Hum has a really nice battery-powered toothbrush or rechargeable toothbrush, and sometimes they're not as vigorous as some of the electronic toothbrushes you have, because sometimes they're very loud and sometimes the vibration is too forceful. The Plaque Vac toothbrush is one that connects to a suction for those who have say mouth problems, swallowing problems, salivary problems. They can't swallow too much, or they tend to choke easily. It connects to like a Gomco suction. And those are some of the things that can be helpful.
Very, very good tips and resources for everyone to take a look at. If you would, in our final couple of minutes here, if you would just touch on the AADMD and the niche program and the guidelines that are out there.
Well, great. Like I mentioned before, not having well-trained practitioners sometimes makes it a barrier. Not too long ago, the American Academy of Developmental Medicine and Dentistry worked very diligently to help change the Commission on Dental Accreditation standard to make sure that every graduate from a dental school and dental hygiene school is competent in both the didactic and the clinical experiences in treating patients with developmental disabilities. So this is accounting for some of what we're trying to do. So because it's a new standard, every school has to meet it. And we know that every dental school does not have special care clinics that take care of this population. We also know that it's difficult to find lecturers or presenters or facilitators in this topic. And we also know that a lot of people say, well, we don't have the person to teach it, and we don't have the materials to teach it with. So they created what's called a niche project, which is the National IDD Curriculum for Health Education project for dentistry. So we sought out 80, 90 different authors throughout the country who are experts to write in educational topics of what IDD means in terms of a transdisciplinary care situation, and created this toolkit called Niche Curriculum at nichecurriculum.org to help with education in all fields, all healthcare fields. And this is to bump up the game, if you will, for all dental schools to have a resource, and even any kind of non-dental schools, any oral health educators, medical, nursing, OT, speech, language pathology, PT, to utilize this curriculum or toolkit. And so we've actually, Colgate partnered with us to create a 2-pager, which you see here on the QR code, on guideline for caries management for special health care needs patients. So much of what I covered is on this. So if you go to QR code, whether you're the patient's parent, or whether you're the doctor or the clinician, or whether you're a nurse or DSP, if you click on it, it might have some helpful guidelines that you can actually bring to the dentist and say, hey, I have this sort of handy tool, and some helpful hints as well.
Great information there. A few other resources are, there are links here to the American Academy of Developmental Medicine and Dentistry, of which Dr. Wong and myself are both actively involved with. The Special Care Dentistry Association, the International Association for Disability and Oral Health, the Helen Journal of Human Exceptionality, which we are going to write an article based off of this presentation today that will be published at a future date, and the Special Olympics International Special Smiles Program. I want to remind you that there is an additional handout besides just the slides about dental causes of adverse behaviors in people with IDD that you can download. It's from the book Clinical Pearls in IDD Healthcare. I want to take a minute just to say, Dr. Wong, thank you so much for providing this extremely valuable and important information. There are lots of questions that we simply don't have time to get to, but what I'd like to do is let's do a part 2 of this, and we can even start with some of the questions that people have asked. Would you be willing to come back and do this again one day?
Absolutely.
I'll put you on the spot here.
I absolutely would. And thank you for your interest in this. And truthfully, I think the dentistry, if we approach it with more prevention, I think we can avoid a lot of heartache, headaches, and toothaches.
Agreed. Prevention is the key, and that's what we focus on at Intellectability is preventing preventable health issues, health problems, hospitalizations, and preventable deaths. And one of the ways we do that is through our academy, which is filled with lots of e-learning courses, and we're very excited to announce the addition of 2 brand new courses. And when I say brand new, I mean we just released them. One is on trauma-informed support in people with intellectual and developmental disabilities, and the other one is on person-centered thinking. It's a full e-learn version of the course. And not only do we have this now for people with intellectual and developmental disabilities, person-centered thinking in that area, but also another version that is about how to support people in person-centered ways who are aging. So take a look at our website to learn more about those courses and all of the other ones that we have. We really want your feedback, so please take a few minutes to fill out the surveys that are linked in the chat. And also, a couple of people have asked about the podcast, the IDD Health Matters podcast. You can find it on most podcast platforms, including YouTube. There's the video version of it. You can access it through that QR code or just search IDD Health Matters to learn more. Dr. Wong was an early guest in the podcast, so you'll find him there. And this will be turned into another podcast as well. Thank you all so much for joining us today. We really appreciate your interest, your support, but more importantly, I want to thank everybody for the incredible work that you do in this field to support good health, including oral health, for everyone, including people with intellectual and developmental disabilities.
All right, thank you so much, Dr. Escudé and Dr. Wong. We hope you guys enjoyed this presentation and that it inspired you with lots of ideas. If you'd like to explore those ideas with our team, we are happy to help and we are here to help. You can request to connect with one of our sales representatives to discuss all the ways that Intellectability's tools and training service might support you and your organization. Again, please just take a minute to fill out that short survey. Have a great rest of your day, and thank you guys for joining us.